More than 4 million Americans are living with Sjogren's disease right now. 9 out of every 10 of them are women. Every single day, someone new begins the long, quiet process of trying to find out what's wrong with their body, only to be told, again and again, that nothing is wrong at all. For most people who are eventually diagnosed, years will pass between the first symptom and the day a doctor finally puts a name to what they're experiencing. Some studies put that average delay at 2 years. Others put it closer to 6. 7 years of doctor's visits. 7 years of being told it's stress, or menopause, or simply getting older. 7 years of a body sending signals that no one around them, sometimes including the person themselves, knew how to read. Here is something important that most families are never told clearly, and that we are going to say plainly right at the start of this video, because honesty matters more than tidiness. Sjogren's disease does not have one official, universally agreed, numbered staging system the way some other diseases do. There is no single blood test or scan that tells a doctor, with certainty, you are in stage 4 of 7. What does exist is real, published, peer-reviewed research describing how this disease typically begins at the cellular level, how it is classified once it is found, and how it can, in a smaller group of patients, progress further. Tonight, we are going to walk through that research as 7 stages. We built this framework by combining 2 models that rheumatologists actually study and use in clinical practice, one describing the earliest, often invisible biological beginnings of the disease, and one describing its clinical severity once it becomes measurable. We will tell you clearly where the science is well established and where it is still an evolving, incomplete picture, because you deserve to understand the real shape of this disease, not a simplified or falsely tidy version of it. We are going to look at what is actually happening inside the body at each of these 7 stages. What the person living with it is experiencing, often silently, often long before anyone believes them. What families, spouses, and caregivers go through as the disease moves and changes over months and years. And what decisions and conversations matter most at each point along this road. Toward the end, we will talk about what the current research actually supports doing, starting today, regardless of which stage concerns you or someone you love. Subscribe now if you want health information explained clearly, sourced from named, published research, delivered without exaggeration and without unnecessary fear. Let's begin at stage 1. Before we continue, I built something specifically not for just tracking and doctor's appointment. It is called Sjogren's Ultimate Symptom Map and Diagnostic Action Plan, and it walks you through exactly which symptoms to track not just for Sjogren but also for MS and RI. Drop symptom map in the comment, and I would send the link for you to access it. Stage 1 is initiation. This is the silent trigger, the true starting point of the disease, and it is a stage with no symptoms and, as far as current science can measure, no detectable markers at all. Somewhere, in a way researchers are still working to fully map, a combination of genetic susceptibility and an environmental trigger, possibly a viral infection encountered years earlier, causes the immune system to begin making a critical and consequential mistake. It starts to misidentify the body's own moisture-producing glands, the ones responsible for tears and saliva, as something foreign and threatening. This process has a name in immunology. It is called loss of immune tolerance, and it is the true biological starting point of Sjogren's disease, the moment before anything else has happened, before any symptom, before any lab value has moved outside a normal range. At this stage, a blood test drawn from this person would come back completely unremarkable. No autoantibodies would be present. No inflammatory markers would be elevated. A scan of the salivary or tear glands would show healthy, undamaged tissue. If this person walked into a rheumatologist's office at this exact moment for an unrelated concern, a full and careful examination would find absolutely nothing to flag, because clinically, there is nothing yet to find. The disease exists only as a biological process just beginning to unfold, invisible to every test currently available to medicine. And yet, the immune dysregulation has already started. This is the part of the disease that current science can describe conceptually, through research and through population studies, but cannot yet detect in a specific living person before it produces some kind of measurable signal. There is no test today, no matter how advanced, that can identify a particular individual as being in stage 1. This stage exists in the research literature as a reconstructed starting point, built by scientists studying blood samples and health records after the fact, in people who were later diagnosed, tracing backward to understand when the disease process most likely began. for yourself. If you have a family history of Sjogren's disease, or of another autoimmune condition such as lupus, rheumatoid arthritis, or autoimmune thyroid disease, it is worth understanding that autoimmune conditions frequently cluster within families, sharing overlapping genetic risk factors. Loss of immune tolerance of this kind can begin years, sometimes decades, before any test we currently have would catch it. There is nothing specific to test for at this exact biological stage. But it is worth knowing your family's autoimmune history in detail, and mentioning it clearly and specifically at your next physical exam, so that it becomes part of your medical record rather than a fact that lives only in family conversation. For a loved one. If you are supporting someone who has just received a Sjogren's diagnosis, it is worth internalizing that stage 1 likely happened years, and quite possibly decades, before anyone had any reason at all to look for this disease. The diagnosis your loved one just received is not the beginning of their illness. It is a marker planted much further down a road that started quietly, imperceptibly, a very long time before either of you had any reason to suspect anything was wrong. Stage 2 is the preclinical stage, and this is where the disease first becomes detectable in the body, even though it still cannot be felt. This is one of the more striking and well-documented findings in the entire field of Sjogren's research. A study published in the journal Arthritis and Rheumatology in 2015 used blood samples that had been carefully banked years, sometimes decades, before the patients involved were ever diagnosed. Researchers went back and tested those old samples for the hallmark autoantibodies associated with Sjogren's disease, specifically anti-Ro, also called SSA, and anti-La, also called SSB. What they found was remarkable. These autoantibodies could be detected in the blood as much as 18 to 20 years before a person was ever formally diagnosed with the disease. And researchers could not even rule out the possibility of even earlier positivity, because for many of the patients studied, the very earliest bank sample available to test was already positive for these antibodies. 18 to 20 years. Sit with that number for a moment. A person diagnosed with Sjogren's disease at 55 years old may have been quietly carrying detectable, disease-specific autoantibodies in their bloodstream since their mid-30s, with absolutely no symptoms, no dryness, no fatigue, nothing at all that would have sent them to a doctor's office. The disease is measurably present in the blood. The person feels completely, entirely normal. And no one is looking for it, because there is no symptom yet prompting anyone to look, and there is no routine screening test offered to healthy people without a reason to suspect something is wrong. This stage matters enormously for understanding why Sjogren's disease so often feels, to the people living through its early moments, like it came out of nowhere. It did not come out of nowhere. It had already been quietly present, detectable in principle if anyone had thought to test for it, for years before the first hint of a symptom ever appeared. For yourself. This is not currently a stage where routine population screening exists. Antibody testing for anti-Ro and anti-La is not recommended for people who have no symptoms at all, and testing everyone preemptively would create more confusion than clarity given how common false positives and incidental positives can be in isolation. But if you have a first-degree relative, a parent, sibling, or child, who has Sjogren's disease, lupus, or another connective tissue disease, it is entirely reasonable and worthwhile to mention that family history clearly and repeatedly at your regular checkups. This gives a doctor important context to draw on later, if and when symptoms ever do appear, rather than starting from zero. For a loved one. If a family member has just been diagnosed, this stage helps explain something that families often struggle to make sense of emotionally. Why did no one catch this sooner? In a great many cases, the honest answer is that there was nothing yet to catch. The biology of the disease was running years ahead of any symptom that could have prompted someone to look for it. No one failed to notice something obvious. The disease itself was, by its nature, unnoticeable at this point. Stage 3 is asymptomatic to early glandular disease, and this is the stage most consistently, and most understandably, dismissed by doctors, by families, and often by the person experiencing it themselves. This is the stage where measurable glandular damage begins, even while the person's day-to-day symptoms remain mild, inconsistent, and easy to explain away. Underneath a microscope, a small biopsy taken from the inner lip at this stage, sampling minor salivary glands, would often reveal something called focal lymphocytic infiltration. This means clusters of immune cells have begun gathering around the tissue of the salivary glands, gradually disrupting their normal ability to produce saliva. Objective: measurable testing may already show reduced function even at this point. A Sjogren's test, which measures how much moisture the tear glands produce over a set period of time using a small strip of paper placed at the edge of the eye, may already register below normal. A salivary flow test, measuring how much saliva is produced over a fixed period, may already show reduced output. The biological damage is measurable, documentable, real. But what the person themselves experiences day to day is often still mild, and often genuinely intermittent, which makes it deceptively easy to dismiss. A dry mouth first thing in the morning that seems to resolve by the time they've had breakfast and a cup of coffee. Eyes that feel gritty and irritated by the end of a particularly long day, especially after screen time or time spent outdoors in wind. A level of fatigue that gets attributed to a busy season at work, a stretch of poor sleep, getting older, or simply the ordinary wear of daily life. None of these symptoms, taken individually, would alarm most doctors, and none of them would necessarily alarm the person experiencing them either. This is the stage most consistently dismissed, and it is worth saying plainly that this dismissal is not always unreasonable on its face. These same symptoms, dry mouth, gritty eyes, persistent tiredness, are extremely common in normal aging, in menopause, in simple dehydration, in seasonal allergies, in stress, and in 100 other unrelated and far more common conditions. A population-based study conducted in Taiwan, drawing on a national health insurance database, found that the median time between the onset of dryness symptoms and an eventual Sjogren's diagnosis ran well over 2 years. Other patient cohorts studied elsewhere have found average delays approaching 6 years, largely because these early symptoms simply do not point clearly or urgently toward this one specific disease among many possible explanations. For yourself. If dryness, whether in your eyes or your mouth, or a persistent, unusual level of fatigue has become a genuine, consistent, lasting pattern rather than an occasional inconvenience tied to a bad night's sleep or a stressful week, that distinction matters enormously, and it is worth acting on. Ask your doctor specifically, by name, for a Sjogren's test to measure tear production, an unstimulated salivary flow measurement to assess saliva output, and blood testing for anti-Ro/SSA and anti-La/SSB antibodies. These are not part of a routine annual physical exam in most practices. You may well need to request them specifically and clearly, and it is entirely appropriate to do so. For a loved one. If someone close to you keeps mentioning dryness, or exhaustion, or discomfort in a way that feels different in tone and persistence from an ordinary passing complaint, take that seriously rather than reflexively reassuring them out of the conversation. A pattern of symptoms that persists over weeks and months, rather than resolving on its own, deserves to be documented and discussed with a doctor, even when an initial look suggests there is nothing seriously wrong. Being taken seriously at this early, ambiguous stage can meaningfully shorten the years-long path to an eventual diagnosis. Stage 4 is overt glandular Sjogren's disease, and this is the stage where most people are formally, clinically diagnosed. By this point, the hallmark features of the disease have become clinically unmistakable to a doctor who is specifically looking for them. Persistent dry eyes and dry mouth that simply do not resolve with hydration, no matter how much water is consumed throughout the day. Genuine difficulty swallowing dry foods like crackers or bread without a liquid to help move them along. Dental decay that accelerates noticeably, because saliva plays a crucial, often underappreciated protective role in the mouth, buffering acid and washing away bacteria, a function that is now measurably compromised. Joint pain that comes and goes but never fully disappears. A level of fatigue that does not improve meaningfully with rest, no matter how much sleep is prioritized. Salivary gland swelling may appear, sometimes visibly, along the jawline or in front of the ears. Blood tests at this stage typically confirm the presence of anti-Ro/SSA antibodies, and less frequently, anti-La/SSB antibodies. If a lip biopsy is performed, it typically shows a clear, quantifiable focus score consistent with the 2016 American College of Rheumatology and European Alliance of Associations for Rheumatology classification criteria, which represents the internationally agreed diagnostic standard used by rheumatologists around the world to confirm this disease. At this stage, the disease is still largely confined to the exocrine glands, meaning the tear ducts, the salivary glands, and related moisture-producing tissue throughout the body. This corresponds closely to what rheumatologists have long referred to as stage 1, or glandular Sjogren's disease, within the classical 3-stage clinical model of this illness. It is important, and genuinely reassuring, to understand that most people who are ultimately diagnosed with Sjogren's disease will spend years, often a full decade or more, living primarily within this glandular stage. A substantial share of patients, in fact, never progress meaningfully beyond it at all. This is also, quite deliberately, the stage where the most valuable long-term planning tends to happen. Not because the disease is immediately life-threatening at this point for most people, because for most people at this stage, it simply is not. But because this is the point at which a person typically has the greatest clarity, energy, and stability to build a thoughtful, sustainable management plan, before fatigue, pain, or any future systemic involvement, should it occur, makes that kind of careful planning more difficult. For yourself. If you have just been diagnosed, ask your rheumatologist directly about the ESSDAI index, which stands for the European Alliance of Associations for Rheumatology Sjogren's Syndrome Disease Activity Index. This is a structured scoring tool used to track whether you show any early signs of systemic involvement beyond the glands, and tracking it over time materially changes how your treatment plan is built and adjusted. Ask specifically, by name, about pilocarpine or cevimeline, two medications commonly used to stimulate saliva and tear production, and about hydroxychloroquine, which is frequently used to help manage joint pain and fatigue, even though the research evidence for its effect on dryness specifically remains genuinely mixed. Begin building a real, ongoing relationship with a rheumatologist now, rather than waiting until something changes to establish that relationship under pressure. For a loved one. This is a good moment to learn the practical, daily realities of this disease together, as a shared project, rather than treating the diagnosis conversation as a single event that is now complete and behind you. Humidifiers for the bedroom. Sugar-free lozenges and gum to help manage dry mouth throughout the day. Prescription eye drops used consistently rather than only when discomfort becomes severe. A more frequent dental care schedule than most people need. Sjogren's disease is best understood as a long, ongoing relationship to manage carefully over years, not a single appointment or a single conversation to simply get through and move past. Stage 5 is early extraglandular involvement, and this marks the point where, in a meaningful minority of patients, the disease begins moving beyond the glands themselves and into other systems of the body. This corresponds to what the classical clinical model calls stage 2, or extraglandular Sjogren's disease. Joint pain at this stage often becomes more persistent, more inflammatory in character, and can sometimes be genuinely difficult to distinguish, at least initially, from early rheumatoid arthritis, requiring careful evaluation to tell the two conditions apart. Peripheral neuropathy can begin to appear, presenting as tingling, numbness, or a burning sensation in the hands and feet, caused by the same underlying immune process now affecting small nerve fibers throughout the body rather than only the moisture-producing glands. Raynaud's phenomenon, a condition where fingers, and sometimes toes, turn white or blue in response to cold temperatures or stress, becomes more common at this stage as blood vessel reactivity changes. Some patients begin developing early lung involvement, which frequently shows up first as nothing more dramatic than a persistent dry cough, or mild breathlessness during physical exertion that wasn't previously present, sometimes years before it is formally identified through imaging as interstitial lung disease. Others develop a measurable decline in kidney function related to a specific condition called renal tubular acidosis, one of the more specific, and frankly underrecognized, systemic effects that Sjogren's disease can produce. The presence of anti-Ro/SSA antibodies, identified back at the time of diagnosis, turns out to carry real predictive weight for this stage. Multiple studies conducted over the years have found a striking, consistent association between the presence of anti-Ro antibodies and the later development of extraglandular disease, including vasculitis, and inflammation of blood vessels, and various blood count abnormalities. This means the antibody profile established years earlier, at the point of initial diagnosis, often tells a rheumatologist a great deal about which patients are statistically more likely to eventually reach this more systemic stage. For yourself. Any new symptom appearing outside the classic pattern of dryness, persistent joint swelling that doesn't resolve, new numbness or tingling in the hands or feet, an unexplained cough that lingers for weeks, unusual swelling in the legs, deserves a dedicated return visit to your rheumatologist, rather than being quietly filed away under the heading of simply getting older. Ask directly and specifically whether your current symptoms warrant pulmonary function testing to check your lungs, updated and expanded blood work, or a nerve conduction study to assess for neuropathy. For a loved one. This is the stage where caregiving begins to matter in ways it may not have before, even though the changes involved are often far less visible than a cast, a wheelchair, or an obvious physical limitation would be. That relative invisibility makes it dangerously easy to underestimate just how much sustained energy managing these symptoms actually requires, day after day, in ways that don't show up clearly from the outside. Genuinely believing someone's account of their own fatigue and pain, rather than quietly measuring it against how well or unwell they happen to look on any given day, is one of the most protective and supportive things a family member can offer at this stage. Stage 6 is advanced extraglandular disease, and this describes a smaller group of patients for whom extraglandular involvement becomes both more severe and considerably harder to manage day to day. Interstitial lung disease, if present, can progress further at this stage, with measurably declining lung function that requires closer, more frequent monitoring, and in some cases, treatment with immunosuppressive medication to help slow that progression. Vasculitis, the inflammation of blood vessels mentioned earlier, can advance to cause visible skin lesions, more significant nerve damage, or, less commonly, involvement of internal organs that requires urgent attention. Persistently low blood cell counts, enlarged lymph nodes that don't resolve, and a condition called cryoglobulinemia, in which abnormal proteins in the blood thicken and can damage small blood vessels particularly in cold temperatures, all become more clinically relevant markers that rheumatologists track closely and repeatedly at this stage, in part because these markers carry meaningful information about what may lie ahead. This stage carries real, substantial physical and emotional weight for the person living with it and for everyone around them. Fatigue at this level is not the ordinary tiredness of a hard week at work. It can be genuinely disabling, limiting basic daily activities in ways that are difficult for people outside the experience to fully appreciate. Chronic pain, the cumulative side effects of long-term immunosuppressive treatment, and the sheer accumulated toll of years spent managing a fluctuating, unpredictable illness all compound one another over time, creating a burden that is more than the simple sum of its individual parts. For yourself. If you are managing advanced systemic disease at this stage, this is a reasonable and important point to deliberately build out your full care team, rather than continuing to manage each new finding as a separate, isolated crisis as it arises. This typically means rheumatology at the center, pulmonology involved if your lungs are affected, and nephrology involved if your kidneys are affected, all coordinating together rather than working in isolation from one another. Ask your rheumatologist plainly and directly what your current ESSDAI score indicates about your overall risk trajectory going forward, so you understand not just where you are, but what the data suggests about where things may be heading. For a loved one. Sustained caregiving for a chronic systemic illness of this severity is genuinely a marathon, not a single difficult season that will simply pass with time. Respite care, support communities specifically for families of people living with autoimmune disease, and simply refusing to carry this responsibility entirely alone all matter enormously at this stage. Watching closely for caregiver burnout in yourself is not a peripheral, secondary concern to the person's care. It directly and materially affects the quality and sustainability of the care you're able to provide over the months and years still ahead. Stage 7 is extraglandular disease with lymphoid malignancy, and this is the rarest and most severe outcome within this entire framework, corresponding to what the classical clinical model calls stage 3. It is essential to be precise and honest about just how rare this stage actually is. The researchers who originally proposed this 3-stage clinical model found that patients who had progressed to lymphoid malignancy made up only about 5% of the overall Sjogren's disease population they studied. 5%. 95% of patients in that research never reached this stage at all. Sjogren's disease carries the highest lymphoma risk associated with any autoimmune disease currently studied, primarily involving non-Hodgkin B-cell lymphoma, which most often arises directly in the salivary glands themselves, the very same tissue where the disease originally began all those years earlier. Warning signs that clinicians watch for closely include a persistent, firm swelling in a salivary gland that does not come and go the way ordinary inflammation typically does, ongoing enlarged lymph nodes that don't resolve over time, unexplained weight loss, night sweats, and, somewhat counterintuitively, a sudden and unexplained drop in antibody levels that had previously been elevated and stable for years, a shift that can actually signal the immune system's abnormal cells are now behaving differently than before. This is, without any question, the stage that families fear most when they hear about it, and it deserves direct, honest acknowledgement rather than euphemism or vague reassurance. It is real, and it does happen to a small fraction of people living with this disease. It is also, importantly, when caught early through the same ongoing monitoring already routinely used to track advanced Sjogren's disease, frequently treatable. Salivary gland lymphomas specifically linked to underlying Sjogren's disease often carry a more favorable overall prognosis than lymphomas that arise without this particular background, in significant part because they tend to be identified earlier, while the disease is often still localized rather than having already spread. For yourself. If you have long-standing extraglandular disease, ask your rheumatologist directly and specifically whether your particular case carries elevated risk factors for lymphoma. Persistent salivary gland swelling, low complement levels on blood work, cryoglobulinemia, and a history of vasculitis all factor meaningfully into that conversation and into determining what monitoring schedule makes the most sense specifically for you. For a loved one. If someone you love reaches this stage, oncology becomes an essential part of the care team, working alongside rheumatology rather than replacing it. The relationships and habits of communication built carefully in all the earlier stages, the plain, honest conversations about symptoms, the trust required to report openly what has changed, become exactly what is needed most now, at the point where clear communication matters more than ever. You have just walked through all 7 of these stages. It's worth pausing to say clearly, one more time, what this framework is and is not. It is not an official, universal, one-size-fits-all staging system the way some other diseases have. It is a research-informed way of understanding how Sjogren's disease can begin, how it is classified clinically once identified, and how it can, for a smaller group of patients, progress further over time. Most people diagnosed with this disease will live primarily in the earlier, glandular stages for years, sometimes for the rest of their lives, without ever experiencing significant systemic or extraglandular involvement at all. That is worth holding on to clearly, especially if a recent diagnosis has left you afraid of a future that, for most people, statistically speaking, does not arrive. Here is what the current research does support doing, starting today, regardless of which stage concerns you or someone you love. Sjogren's disease does not have a single tidy statistic, the way some other conditions do, claiming that a fixed percentage of cases are preventable through specific lifestyle changes. This remains a genuinely active area of ongoing research, not a fully settled one, and it would be misleading to claim otherwise. But there are concrete things the evidence does clearly support.